Thank you for being here. And after hearing all this, the question is how we navigate in this world of shoulder instability and how we can decide at the end what we are going to do. So, these are my disclosures. So, starting to think about this, these are the answers that we gave and we can discuss. So, shoulder instability is a biomechanical dysfunction, and it is a failure of the static and dynamic stabilizers. And it may be a minor problem or a major problem. So, what is important to know is that first-time dislocation is not a benign problem. Sometimes major lesions are even from the first dislocation, and of course they're becoming worse as the episode of dislocation are continued. And we published our findings in traumatic shoulder dislocation, and Bankard repair was very high, heel sacks were very high also. Practically, the lesions were there from the beginning, and of course they became worse. So the classic lesion, the Bankard lesion, was the first to describe, and that was what we were trying to repair. And it became the standard of care for at the 90s. For the oldest, we remembered it. The older, open and then arthroscopic. And the long-term results were initially very good, those that were published, but slowly it was becoming worse as the time of follow-up was increasing. And the goal, we realized that the goal of the operation was not just to put the labrum back to its position, but also to reestablish the tension to all the capsular ligamentous system, both the anterior and the posterior. And to recreate the bump also that stabilized the head. And as the years of follow-up increased, the initial lesion, the essential lesion, we realized it was not the only lesion. And then in 2000 came this article, and this was a complete change now. And the interesting of this, in this article, was that it was published by two orthopedic surgeons that were in favor of arthroscopic repairs. And they were saying, okay, be careful, we can't repair everything at that time arthroscopically. So even for these rugby players, an arthroscopic Bankard repair was a very satisfying operation with very good results. If there was no bone lesions, if there were bone lesions, the results were deteriorating quickly. And then came all this, the discussion about the clinical bone loss, and then came the on-track, off-track lesions. We have discussed them already, and the combination of these lesions that was now the new problem. And slowly we abandon the soft tissue procedures, at least for this type of lesions, and many classifications came trying to give a system of when to do a Bankard repair, combine it with replissage, or do some bone procedure like Latarjet. And the critical bone loss then came to the subcritical level, and then came this very interesting paper from Boileau and Balch. And the very important thing in this paper was that from the risk factors, only 2 of them were risk factors that had to do with anatomy. The rest had to do with the type of patient, the way he was living, what was his sport, and what was the level of participation to sports. So we were looking for anatomy and start looking for something else. And now we know And these are the factors, at least, that we take into consideration. Some as very important: the activity level, the number of dislocations and the age of the first dislocation, the laxity, the constitutional laxity of the patient, the bone defects, of course, and if it is a revision or a primary operation. And so now we know that what we deal with is a patient that has a constitutional laxity, has a level of participation to sports, and then he has a minor or major accident that changed the anatomy. And we have to take all this into consideration. And we must treat it as this. So if we have a patient without a bone loss, then a Bankart repair can be enough. If we have bone loss from the humeral side, we try to reduce the volume of the posterior capsule. If it is a capsular laxity, we try to reduce the volume of the anterior and the posterior capsule. And if we have a substantial bone loss, then we would perform a Bankart repair. And remplissage, it was already mentioned as a way of doing this, and we published our results, and we had in the long term very good results in patients that they had not an inverted reappearance of the glenoid. This was important at that time. We were excluding patients that had substantial bone loss. And we had also the long-term results published, and these long-term results are very satisfying in this type of patients. Then we came in contact with ASA, with Marco Maiotti, and we started using this technique also. And in this technique, the advantage of this technique is that we had a similar result with remplissage. We were augmenting the soft tissue repair that we had done already, and it was quicker and easier to perform and rather cheaper. And as we said before, we used slight small differences as the original from the original way that Marco Maiotti described, but it was the similar idea, it was a similar philosophy. And we performed this type of procedure in hyperlax patients or in patients that we had done a bone block procedure because we opened the interval and we had to reestablish the connections in the interval between the subscapularis and the soft tissue of the rotator interval. Dynamic anterior stabilization was also proposed as an operation for this type of patients, and Dr. Azevento described this before. And then the bone block procedure. And we start using the modified Edenhibinet, arthroscopic Edenhibinet. It was, there were, at that time that we were trying to find how we would go, there were many bone block procedures described. Some of them were open procedures, others were arthroscopic procedures, others were procedures with implant, without implants. And we decided to use the procedure using the iliac bone graft and using the procedure that was described by Ettore Taverna as arthroscopic bone block procedure. We performed it in lateral decubitus and not in Bitzer. We used a bone block that it was from the iliac, anterior iliac crest. We didn't just, we used very few allografts or xenografts. And we used the instrumentation from Smith and Nephew that it was very appealing and made the procedure technically easier. The advantage of this procedure is safeness, because we go from posterior to anterior, avoiding all the neurovascular structures. And also, at the end, we were always repairing the capsule in order to be able to make the bone graft extra articular. And these were images, initial images. And this is another situation, a patient that we didn't use implant, it's just sutures, and shows how the graft is incorporates during the operation. And we re-examined the patients, this with many of them with needle arthroscopy, and this is what we were looking at 6 months after the operation. Very good of healing of the tissue, re-establishing the interval, and also having the bone block to support the capsuloligamentus structures. So, and we published the results of this treatment, the initial results, with the first 30 patients. And now we are trying to publish them again with increased follow-up. And we use it, this procedure is in a critical, in a bone loss of 8%. Then it is also the Latarjet procedure. And Latarjet procedure, we know it's a very effective procedure. Maybe it's one of the most effective procedures in instability surgery. And the problem is that the complications rate is rather high compared to other techniques, and we are very reluctant to use this technique, having quite similar results with the edenhibinate, the arthroscopic bone block, and avoiding the complication. So our thinking now is that we could use the Latarjet procedure in case of failure of edenhibinate, of arthroscopic edenhibinate, instead of vice versa that it is used today. And following these rules, from January 2015 to 2021, we operated 259 patients, and 20% of them was overhead or contact sports. This is the type of patients that we operate. And we performed 63% of them was soft tissue procedures, 36, about 1/3 of them we had bone procedure. This is a change to what we were doing before 2010. And the athletic activity, most of them were recreational athletes, and most of them had something like 2 to 5 dislocations before the operation. The patients that they had a bone procedure were a little more active and also had more dislocations. It's intuitive. And the overall postoperative recurrence rate now it's about 4%, 1.1 in the soft tissue bony procedures, and 5.5% in the soft tissue procedure. And for us, this was a difference to what we were doing before, where the failure rate was about 6 to 7%, reaching 10% for the initial only Bankart procedure. So, keeping in mind all this, we take into consideration always the age of the patient and the age of the first dislocation, the number of previous dislocations, the level of sport participation, constitutional laxity, the severity of bone loss, and also if it is a revision case. And this is what differentiates us between to have a soft tissue or a bone procedure. And we try to have it as a staged procedure. We perform a Bankart procedure with the best way we can. We increase the stability of the stiffness of the capsule and the tension of the capsule by using additional augmenting techniques. And if we feel that this is not enough, we proceed to a bone procedure combined with the previous procedures. Thank you for your attention.